And to talk about one such diagnostic modality during PC, I would like to invite Professor Nauman Naseer Saab to tell us about the practical tips and tricks of FFR. Professor Nauman is the head of cardiology department at Behria International Hospital, Lahore, and by his efforts is definitely no less in any international setup.
I'll jump right into it. Coronary physiology, FFR, IFFR for coronary lesion assessment. And we have known about this hemodynamics and coronary physiology since '79. There was a paper published by Grunzik and other early investigators, and they use balloon dilatation and noticed the gradients across the lesions dropped at that time. But they did not have the luxury of using this 0.104 wires with transducer on it and the FFR, IFR that we can do now. So with fractional flow reserve, the concept is it is a maximal achievable flow as achieved by maximal exercise or maximal hyperemia, and it is directly proportional to the myocardial perfusion pressure, that is hyperemic distal coronary pressure, and is based on constant flow. We know flow is pressure change divided by resistance. So you assume that the microvascular bed resistance is the same at both the points where you're measuring the pressures, and the venous pressure is 0. And in the end, what you're left with is just the pressure on the equation. And the main thing that you need to remember is that PD over PA, which is distal pressure divided by the aortic pressure, and the maximal hyperemia is your fractional flow reserve, and it's less than 0.8. It is considered a hemodynamically significant lesion with that concept. What is instantaneous wave-free ratio? It is a new non-hyperemic pressure-based index of stenosis severity, which is IFR. It is calculated by measuring this resting pressure gradient across a coronary lesion during the wave-free portion of diastole when microvascular resistance is low and stable. It measures the physiologic impact of a coronary lesion in the distal coronary bed, and a value of 0.89 is considered significant in this case. No hyperemia needed for IFR. And these are the non-hyperemic variables. This is IFR and PDPA, not very well clinically validated. That is your mean pressure throughout the cardiac cycle, and for that a value of 0.91 has been suggested, but not clinically well validated. The guidelines have supported FFR and IFR use as a class 1 indication. So basically, this is your pressure from the guide tip, and this is the pressure from the transducer in the wire across the lesion, which is measured. And then after maximum hyperemia, you'll get an FFR ratio over here, and through the diastole wave-free period, you'll get an IFR over here. So these are, pictures from recent cases that we did in the lab, and they're from the text camera, so they're not as good. So this is the Volcano FFR wire that we have in the lab. It's a 0.014 wire. This is the console for the Volcano system that is over there. So before you started, you want to make sure you're getting a nice aortic tracing with an aortic dicrotic notch over there, and you have zeroed properly. Transducer height is fine. You're not changing the transducer height during the case. And then when you open the packet up, this is the coil you're looking at. You're going to flush it, wait for 60 seconds, let the wire stably get wet, and then you hook this up, the cable, this cable over here, and plug it in over here. And once you plug it in the Volcano system, it starts zeroing automatically. And it's saying over here, wait for zeroing. And then it says zeroed now and ready to insert. After that, you're going to take your wire, use an insertion tool, advance the wire through the guide catheter, and bring the wire all the way to the tip of the guide catheter, the transducer portion. The transducer portion is the portion in the proximal part of the radiopaque segment. So this is the transducer portion. You bring it to the guide tip, and then at that point, you're going to take the insertion tool out, flush with saline. Contrast should be out. And the guide that you use should not have side holes, because that can also drop a few millimeters pressures and interfere with the readings. And before you insert the wire, make sure it's clean. There should be no debris on it. So all these steps need to be remembered when you're doing it to get an accurate reading. And then you press the normalize button over here, or equalize button some radio wire system has. And these pressures should be equal. The reading should be 1 over there. So that's when you're ready to pass the wire across the lesion. So this is a case just recently did, somebody with an LED lesion, equivocal chest pain symptoms. So put the wire across the lesion after following the steps of zeroing and equalization. And after putting the wire across the lesion, I pressed on the IFR button, but I did give intracoronary nitroglycerine beforehand. That should be given. And wait after giving nitro as well, and after flushing a good 30 to 60 seconds. After doing that, then we did the IFR, and this came at 0.88. And the FFR after intracoronary adenosine I used, in this case about 100 micrograms, it came at 0.76. So the lesion was significant. I stented that. And after stenting, actually, you can do a remeasurement post-stenting as well by reconnecting the wire over here. Just slide it back, put it in. You just have to align the links properly, and you can use in multiple vessels with that. So that's how you do the FFR wire and setup. Basic, but need to remember all the steps to do it properly. So a reminder again of these steps. Your timer गायब हो गया, I guess. Flush and zero pressure wire. Insert pressure to tip of guide. Remove introducer. Remember to remove it. A lot of people forget it and then need to do it again. So flush guide with normal saline. Equalize pressures. Advance pressure wire distal to the target lesion. Measure resting physiologic index. Now IFR has made life really easy, and that's why the volume of this pressure wire has gone up tremendously because of that. And measure hyperemic FFR if needed now. You don't know, I'll still do it, but I just do intracoronary. Intravenous, is a hassle to use. And then make sure, this is a very important step, that you pull back the wire after doing your measurements across the lesion to check for drift. Because drift can happen in some cases, innate issues with the wire itself or some technical error that you may have made. So what it means is that you pull back the wire, the transducer portion of the wire back into the guide tip, and the pressures should still be equal as they were before you inserted the wire forward. And if they're not, then you need to equalize again and reinsert the wire again. So how do you achieve hyperemia? 140 micrograms per kg per minute, same dose which is used in adenosine. Stress maybe is used over here. It has the side effects. After 2 minutes of infusion is more than enough. You start seeing the effects. The pressures start coming down, and patients do feel dyspnea, issues with AV block. Intracoronary adenosine dose is not like a gold standard. It's been, multiple trials looking at it, and this variation in dose used. I personally use 40 to 60 micrograms dose for the right coronary artery, about 100 to 150 milligrams max for the left coronary artery, and generally it correlates well. So if you have an IFR value which is significant, and I get an FFR which is significant with intracoronary adenosine, it supports my finding good enough. But if it doesn't, then it may mean that we haven't achieved maximal hyperemia, and that's why the FFR is not correlating with the IFR. And always give intracoronary nitroglycerine before you're doing your adenosine to make sure there is no spasm element contributing there. So some of the pitfalls to keep in mind related to measurement, wedging, whipping, and drifting. I'll show the pictures of this. This is the wedging example that you see the aortic pressure is actually wedged over here. And when you pull the guide back, now you can see a clear aortic tracing with a dicrotic notch, and the FFR was significant over here because the aortic pressure was damped over here, so you're getting not a significant FFR. Whipping an example when the wire is actually, the transducer is hitting the wall again and again, and as a result you get a whip. So you just reposition the wire and this whipping thing will go away. Gradient or drift. Now when you put the wire across a significant lesion, it will have this ventricularization appearance in most cases. So if it looks exactly like the aortic pressure tracing as then it might be a drift if you're getting the pressure tracing lower than the aortic pressure and it looks exactly the same. And this is an example of a drift. Patient FFR was 0.78. When you pull back, there's a pressure difference at the of the wire at the guide tip. And when you equalize and advance the wire again, actually the FFR was 0.85. So you have to be mindful of that to pull the wire back and check for drift. Some more case examples. This is an example of an ostial left circumflex here. You can take all the orthogonals views you want, and you could not lay out properly. And so advance the wire. This was on the Radi system, and it was at 0.52. So it was significant. An example of multi-vessel CAD case, so LED, RCA, borderline lesions, very significant circ. You put the wire across all of them. Circ was significant, 0.55, RCA was 0.53, and LED was 0.93. This is an example of after right stenting was 0.95. There is data to show that in incremental decrease in FFR results in adverse outcomes and repeat TLR. So about 0.95 is a good number to have post-stenting. But normally, yes, for appropriate stenting, IVUS is the best thing for stent observation, but FFR also has some data on that. Now, this is a wonderful thing of the co-registration with Volcano Philips system. This gives you a virtual stenting that, especially in diffuse disease, that if you stent in this area, this is what your FF are going to be post-stenting. So it's a really great thing. We haven't had this over here, co-registration, but in US and the IFR combination of co-registration is being routinely used, very helpful. Special scenarios to keep in mind, aortoostal regions, always disengage the guide. Left main, assess both LED and left circumflex and pull back. And remember some of the studies that have been done with left main, not large, a few hundred patients. Out of the left mains, which are 50% lesion, only about 20 to 30% patients on some of these series had actually significant FFR. So before you commit somebody with left main to bypass, make sure that you are sure, and just do an FFR and IVUS to corroborate as well. So, and CTO donor vessel FFR, an example of patient with CTO RCA and an LED lesion, which was 60%. I did an FFR on LED, it was significant, it was 0.78. I opened up the CTO RCA, I did the LED FFR again, and it went up to 0.85. I didn't need to do the LED. So the FFR is not dependent on the degree of stenosis. It is dependent on also the amount of viable myocardium being supplied by that vessel. If it's a tiny circ, which has a tight lesion, that may not be significant. At 80% lesion, a tiny circ may not be significant, and a 60% lesion, the proximal LD will be significant. And if you have a discrepancy between rest and hypercontinence, use your clinical judgment. And physiologic medicine is not recommended in vein grafts, no data. ACS culprit lesions, actually there is reasonable data in non-culprit lesions, and you can use it over there, not in culprit lesions themselves. And severe decompensated heart rate failure, you have to avoid it, because remember, you're assuming the venous pressure is 0 and heart failure is going to be elevated, so you're not going to be having reliable thing. Regarding side branches, just remember there's reasonable data, multiple trials showing that almost 25%, if you see a side branch after stenting, it's 75% stenosed. Only 25% of those branches will have significant FFR. Now, deferred trial, which really put it in the main trial with which FFR got approved. In the deferred trial, actually, it's 15 years data out that it was safe to defer lesions based on an FFR greater than 0.75. FAME trial was multivessel disease intervention guided by FFR versus angiography guided, and it ensured the FFR guided patients did better with less resource utilization because less stents were needed. Then after the Courage trial, Orbiter trial, there was a need to see if hemodynamically significant lesions were done, you will have better outcomes. And in that case, there was shown that the MACE was better with FFR guided patients, and this blue line is the FFR guided, and these were the medically treated patients with FFR greater than 0.8, and red was the patients who were deferred to medical therapy. So this was driven by urgent revascularization, which was actually ACS in most patients. And with the this is a sweetheart trial, and the defined flare trial, IFR is as good in clinical outcomes as the FFR. It has been shown. It is a class 1 recommendation based on this data by guidelines that FFR, IFR to be used for intermediate stenosis, and class 3 if they are not significant to stent or a lesion in that scenario. So the value of experience is not in seeing much, but in seeing wisely. Thank you.